Okay, hi. This is a video on HIV drugs. You can go ahead and pause and try to answer this yourself, but I'm going to go ahead and read it, and then we're going to go over the answer. A 48-year-old HIV-positive man comes to the physician for a routine follow-up. He has been on antiretroviral therapy for the past 8 months, which includes the nucleoside analogs zidovudine and lamivudine, along with the protease inhibitor combination lopinavir-ritonavir. He is also on prophylactic treatment with trimethoprim sulfamethoxazole for pneumocystis jirovecii, pneumonia, and azithromycin for Mycobacterium avium complex. 2 weeks ago, his leukocyte count was 1,300, 60% segmented neutrophils. His plasma HIV viral load remains undetectable. An adverse drug reaction causing suppression of bone marrow proliferation is suspected. Which of the following medications is the most likely cause? And hopefully you came to the correct answer, which is zidovudine. So if this question seemed confusing or difficult, I don't blame you, but this was actually seen on NBME 24 with similar or if not exactly the same answer choices. The problem with this question and this type of question is that it feels like more than one answer choice can be correct. And theoretically that is true. However, the USMLE, NBME, they all want the most correct answer. Now, what does that mean? In this context in particular, zidovudine is more associated with bone marrow suppression than lamivudine is, even though both of them are in fact theoretically able to cause bone marrow suppression because they are both in the same class of NRTIs. Nevertheless, zidovudine being more associated with bone marrow suppression, that's the correct answer. And so once again, this is another wonderful example of the correct answer being on a spectrum, which again, this is by the USMLE test writers' own admission that they do this on some of these questions, where they will put more than one correct answer theoretically, but only one is most correct. So with that being said, let me just say that the HIV drugs are absolutely worth memorizing. Their side effects, especially their unique side effects, are absolutely worth memorizing. They will ask you at least one question about the HIV drugs, if not more. So the highly active antiretroviral therapy, sometimes also known as HAART, I think nowadays they call it combination antiretroviral therapy, CART, or sometimes just ART, consists of at least 3 antiretroviral drugs from at least 2 different drug classes. And most commonly, you're going to have 2 drugs from the nucleoside reverse transcriptase inhibitors, which are the NRTIs, and 1 drug from another class, such as the non-nucleoside reverse transcriptase inhibitors, or the protease inhibitors, or integrase inhibitors. So you'll notice that this patient in particular was on a similar therapeutic regimen. They had 2 NRTIs, which was zidovudine and lamivudine, and then the protease inhibitor combination lopinavir-ritonavir. Now, on the exam, they may or may not put this combination. They might just put one protease inhibitor, but you'll often see ritonavir added to another protease inhibitor. And that combination is because ritonavir can pharmacokinetically boost the levels of other protease inhibitors because it is a CYP450 inhibitor. Now, this point was actually asked on an prior NBME as well. I can't remember which one, but they did ask directly, why do they add ritonavir to another protease inhibitor? And the answer is because it is able to boost the levels of the other protease inhibitor. So in effect, because it is a P450 inhibitor, it allows slower metabolism of the other drug. Therefore, that drug will last in the bloodstream longer, and its therapeutic effect has more of a chance to take effect. So I've put the HIV drugs here on this table. This is a 2-page table here. I'll go over it with you now. So you organize them into 5 classes. We have the first one, which is the entry and fusion inhibitors, then integrase inhibitors, the nucleoside reverse transcriptase inhibitors, non-nucleoside reverse transcriptase inhibitors, and then the protease inhibitors. Okay, so just immediately, the integrase inhibitors are drugs that have tegravir in the name. Tegra, you'll see I bolded here. Hopefully you can see it. There's tegra here and tegra here. So that's how you know when you see a drug that has like raltegravir or elvatagravir, the tegravir portion is telling you it's an integrase inhibitor. Similarly, you have at the end here, the protease inhibitors. They have navir as a common suffix within them. So indinavir, ritonavir, the navir tells you that it is a protease inhibitor. So going back here to the entry or fusion inhibitors, the purpose of these drugs is to prevent viral entry. So this is going to be mechanism of action, and these are the side effects. I didn't list any side effects for entry fusion inhibitors. There aren't any that are particularly important for the exam purposes. The first drug in the entry or fusion inhibitors is maraviroc here, and this one will bind and inhibit CCR5, which is on the CD4 positive T cells. It prevents binding of GP120 onto CCR5. This inhibits HIV entry and fusion by preventing penetration. Okay. The next entry or fusion inhibitor is infurvatide. This one will bind to and inhibit GP41 on the HIV virion itself. It prevents GP41 from binding to the T cell membrane, and this will inhibit entry by preventing attachment. So what I'm highlighting is what I believe you should make associations of with maraviroc and CCR5, and then preventing penetration under the entry fusion inhibitor category. Infurvatide binds to and inhibits GP41, prevents attachment. This is under entry and fusion inhibitors. So if you were to have, let's say, a flashcard, the things that are highlighted is what I would just put on the card. Keep it short. So next are the integrase inhibitors. These, the mechanism of action here is to inhibit the enzyme integrase, which integrates its viral DNA into the host's DNA. So this is the step that's being stopped here with the integrase inhibitors. Again, they have tegravir in the name. Side effect is that they can increase creatine kinase. Raltegravir and elvatagravir are the drugs under the integrase inhibitor list. There's also dolutegravir. Nothing particularly special about these drugs, just recognize the name in their category. Next are the nucleoside reverse transcriptase inhibitors. These are the most important. These are the NRTIs. They are prodrugs that need to be phosphorylated. Okay, that's important. They need to be phosphorylated first to become active. They competitively prevent nucleosides from being added to the growing HIV or DNA strand. I wrote nucleotide here, but I meant nucleoside. There is one nucleotide reverse transcriptase inhibitor we'll talk about in a minute, but it's preventing nucleoside addition to the DNA chain. It does this by preventing formation of a 3,5 phosphodiester bond, because these drugs, they lack the 3' hydroxyl group, so there's nothing to add on to them afterwards. So they basically terminate the chain. The side effects here are peripheral neuropathy, bone marrow suppression, which is what our initial question was about. You can treat the bone marrow suppression with granulocyte colony stimulating factor, GCSF, and they can also cause lactic acidosis. So the list here, abacavir can cause hypersensitivity reaction in patients who are HLA B5701 positive. So this will be a point that you'll see often in resources. It's something to take note of. Didanazine can cause pancreatitis. This is a very important association. It's unique. So if you see a patient on HIV treatment and they tell you that the patient is exhibiting signs of pancreatitis, very likely the answer will be didanazine, or at the very least, a nucleoside reverse transcriptase inhibitor. Emtricitabine is safe to use during pregnancy. Any patient who's taking efavirenz who then gets pregnant can be switched off of efavirenz and then take emtricitabine. The reason is because efavirenz is actually not safe during pregnancy. Zidovudine is a fan favorite. They like to ask about this one in particular. Classically, this HIV drug is given intrapartum to pregnant women and given to neonates for 6 weeks, starting within 12 hours of birth if the mother is HIV positive, in order to prevent vertical transmission. Lamivudine and then stabudine. These are two that you should just know are NRTIs. Tenofovir is the one that I was talking about earlier. Tenofovir is the only nucleotide reverse transcriptase inhibitor. And again, the difference between a nucleoside and a nucleotide. A nucleoside is a nitrogenous base plus a sugar, but a nucleotide is a nitrogenous base plus sugar plus a phosphate group or groups. Everything else in this category in the NRTIs are actually nucleosides. Tenofovir is the only nucleotide. So it's easy because tenofovir has a T in it, so that's a good way to remember it. The non-nucleoside reverse transcriptase inhibitors, or NNRTIs, these are going to bind a different site on the reverse transcriptase enzyme and create a hydrophobic pocket that slows down DNA synthesis. They do not require phosphorylation the way the NRTIs do. I think of note, something to keep in mind is that these drugs are not effective against HIV-2 reverse transcriptase. Side effects here are rash and hepatotoxicity. You have efavirenz here, which can cause vivid dreams as a side effect, which is a very unique side effect. It's also not safe in pregnancy. Delaviridine also contradicted in pregnancy. Nevirapine is just one to keep in mind in this category. Of the protease inhibitors, these will inhibit the enzyme protease, which cleaves HIV proteins into smaller functional proteins. Okay, this process for the HIV virus is called maturation, and therefore these drugs prevent viral maturation by inhibiting protease and preventing protein cleavage. So I think that's an association you should keep together. So protease inhibitors, the fact that they are Navir drugs, that's in their name, that protease cleaves HIV proteins for maturation, and these drugs prevent HIV maturation by preventing viral protein cleavage. Some of the side effects here include insulin resistance, type 2 diabetes, hyperglycemia, lipodystrophy, which they have asked about before on NBMEs. This is going to be fat redistribution that seems somewhat similar to Cushing syndrome. They like to ask about fat that's suddenly in the back of the neck while on these drugs. So you should probably think of a protease inhibitor at that point. If a patient has both HIV and tuberculosis, you want to avoid giving them rifampin because that is a CYP450 inducer, and that would increase the metabolism of these protease inhibitors, which would then cause them to be flushed out of the body faster, right? So then they can't have a therapeutic effect. So you don't want to give these drugs with something like rifampin, which would heighten the protease inhibitor's metabolism. Instead, for a patient with HIV and TB, you can give rifapentine. The drugs here include indinavir and ritonavir, lopinavir, and atazanavir. With indinavir, you might see nephrolithiasis or just nephropathy in general. This is a specific side effect. With ritonavir, it itself is a CYP450 inhibitor. It is added to other regimens of protease inhibitors because of its boosting effect on the other protease inhibitors. We talked about that a bit ago. So this is a point definitely to know about ritonavir. They like to add it with another protease inhibitor such as indinavir or lopinavir. Okay, and in our patient, I believe we had the combination of lopinavir and ritonavir. Okay, so that's it. I wish you luck, and I'll see you in the next one.